If you've been told that back surgery is your next step, we want you to hear something before you schedule that procedure. There's a category of treatment that sits between physical therapy and surgery that most patients are simply never offered. Not because it doesn't exist, not because it doesn't have evidence behind it, but because the standard referral pathway in spine care usually doesn't include it. Today, we're going to tell you what that category is, what the evidence actually says, and honestly, who it's right for and who it isn't, because it's not right for everyone, and we're going to be straight with you about that. At Regen House, we focus on regenerative medicine for musculoskeletal conditions, including back pain that hasn't responded to conventional care. So this is going to be an honest breakdown of what the evidence supports when it comes to avoiding back surgery, what works for which conditions, and just as importantly, when surgery is genuinely the right answer. We'll cover why the standard pathway tends to skip regenerative options, the real risks of back surgery that you're rarely told up front, which back pain presentations respond best to regenerative care the data shows, when surgery is the correct call, and what a proper evaluation actually looks like. Let's get into it. If you're frustrated, that frustration is legitimate. So let's talk about what's actually happening behind it. The standard spine care pathway looks like this. You start with physical therapy, then anti-inflammatory medications, then cortisone or epidural steroid injections. And when those don't fully solve it, you get a referral to a surgeon. That's the road almost everyone is walking. Here's the thing. Most referring physicians have a specific toolkit: PT, referrals, pain management, and a surgical consult. That's the network they work within. Regenerative medicine sits outside that network, not because it doesn't work, but because most spine referral systems just don't include it as a step. So think about what failed conventional care really means in practice. You tried PT for 6 to 12 weeks, check. You had cortisone or epidural injections, check. The next step you were offered was surgery, but the step that got skipped entirely was biologic treatment aimed at the actual pain generator. This isn't a failure of the individual doctors involved. They're doing what their pathway tells them to do. It's a gap in the referral pathway itself, and that gap is actually what most patients never get told about. Now, before we get to what fills that gap, let's be clear about something up front. Back surgery can be the right call for the cases we'll talk about later. It absolutely is. But a procedure is permanent, and you deserve to walk in knowing the actual numbers, not just the best case version. So here's what the published data says plainly, starting with the most patients have never even heard a name for. When someone goes through back surgery and still has significant pain afterward, there's a clinical term for it: failed back surgery syndrome. And it isn't rare. According to the published clinical reference literature, failed back surgery syndrome is reported to affect up to 40% of patients after back surgery. And when you break it down by procedure, the failure rate for lumbar fusion runs as high as 46% and up to 25% for microdiscectomy. Read that again. For fusion specifically, by some estimates, nearly half of patients don't get the relief they were after. And a lot of that shows up fast. In one large study of over 100,000 lumbar surgery patients, 5.4% were formally diagnosed with failed back surgery syndrome within just 6 months, and 8.4% within the first year. That's not rare years down the road complication. For a meaningful number of people, the pain is still there almost right away. Then there's the question of needing surgery again. A nationwide cohort study found the cumulative rate of needing a second operation was around 14% by 5 years, and projected to reach roughly 23% by 10 years. So part of the honest picture is that a first surgery is not always the last one. Now, why does this happen? A few documented reasons. Sometimes a disc reherniates. Sometimes scar tissue forms around the nerve. Sometimes removing or fusing one segment puts extra load on the segment next to it, which then breaks down too. That last one even has a name: adjacent segment disease. None of this means surgery surgery is bad, it means surgery is a serious intervention with real measurable failure and complication rates, and those numbers belong in your decision before you schedule, not after. And to say it as plainly as we can, we're not telling you to avoid surgery. We're telling you that the fact that it isn't guaranteed to fix the pain is exactly why it's worth making sure you've genuinely evaluated every real option first. That's the entire reason this video exists. Here's something most people are never told. Not all back pain is the same. The pain generator matters, and it matters a lot. In chronic lower back pain, there are three main generators. The first is discogenic pain, which is damage or degeneration to the disc itself. Things like annular tears or a disc that's lost its hydration. The second is facet joint arthritis, which is degeneration of the small joints at the back of the spine, and it tends to be worse with extension when you arch backwards. The third is SI joint dysfunction, which is inflammation and ligament laxity at the sacroiliac joint, and it's often worse when you load one leg at a time. So what does a good candidate actually look like? For disc pain, we're generally looking for a disc that's structurally intact, not collapsed, with a confirmed discogenic source and earlier grade degeneration rather than end stage. For facet arthritis, early to moderate involvement with confirmed facet-mediated pain. For the SI joint, a source confirmed with a diagnostic block. And across all of these, one key factor, no progressive neurological deficit. That's an important line. And to be equally honest about what falls outside the supportable evidence, severe structural instability that needs hardware. Cauda equina syndrome, which is a surgical emergency, not a regenerative case at all. We'll come back to those because they matter. The data here is more specific than most patients ever get to hear. Let's walk through it. Let's start with the facet joints, one of the most common sources of lower back pain. A 2024 pilot study injected stem cell-derived exosomes, which are the signaling vesicles these cells release, directly into the lumbar facet joint. Over the 3-month follow-up, there were no adverse events, and the group saw significant improvement, with disability scores improving by roughly 58% and pain interference over 70%. It's an early study, but it's pointing in a clear direction for facet-mediated pain. Now zoom out to the broader picture. A 2024 review looking across the lumbar regenerative literature found that roughly 50 to 55% of patients experience meaningful pain relief at 6 months with biologic therapies, and it noted that stem cell results were comparable to the other biologics studied. Now, a lot of that underlying data comes from disc-targeted research rather than the facet approach we just covered. So we share it as a general signal for the category, not a number to pin on any one treatment. But the direction is consistent. For the right candidate, these are real, measurable improvements. And that phrase, the right candidate, is the whole game. And it isn't just exosomes. Early clinical work injecting mesenchymal stem cells directly into the facet joints and surrounding structures, rather than into the disc, has reported meaningful improvement in lower back pain with a strong safety profile, and notably without the added risks that come with the disc space injection. That matters because the delivery route is part of the safety picture, not just the biologic itself. If you've been on this back pain journey for a year or more and surgery has already been mentioned, subscribe. Every month we break down exactly this kind of specificity. And if you want to see the video on what's actually generating your back pain before you decide anything, we'll link that next. Now, this is the section that makes everything else in this video credible, because regenerative medicine is not the right tool for every case, and anyone who tells you otherwise isn't being straight with you. There are presentations where surgery is genuinely the right next step. The first is Cauda equina syndrome, which involves bowel or bladder dysfunction along with back pain. That is a surgical emergency. Do not delay. Do not wait. Do not try anything else first. The second is severe structural instability, high-grade spondylolisthesis, or a failed disc segment with gross instability. And the third is true spinal stenosis with severe functional limitation after you've genuinely failed every other option. So here's the honest statement. If you have any of these presentations, surgery is the right next step, and we'll tell you that directly. Regenerative medicine is a real option for the right case. It's not a universal alternative, and we'd never want you to delay a necessary procedure chasing one. So let's say your case doesn't fit the surgical categories. What should you bring, and what should you expect? Bring everything. All your prior imaging, your MRI and any x-rays, your full prior treatment history, and your current medication list. The more complete the picture, the better the evaluation. A proper evaluation has a few parts. First, an imaging review, identifying your disc grade, any facet involvement, and the overall structural integrity of the segment. Second, pain generator identification, figuring out which structure is the most likely source of your specific pain. Third, consideration of a diagnostic block, which is a way of confirming the source before anyone injects a biologic. And fourth, protocol design, which biologic, how many sessions, and what the timeline realistically looks like. And here's what you should feel free to ask in any consultation, ours or anyone else's. What is my specific pain generator? Am I a candidate based on my imaging? What biologic would you recommend? And why that one? And what timeline for results should I realistically expect? If a clinic can't answer those clearly, that tells you something. So here's the whole picture. Between conventional care and surgery, there's a clinical step that most patients are simply never offered. For discogenic back pain, facet arthritis, and SI joint dysfunction, regenerative biologics have published evidence for meaningful improvement in pain and function. This isn't a miracle path, and we're not going to pretend that it is. It's not the right path for every case, and for some presentations, surgery is genuinely the answer. But for the right candidate, it is a real evidence-supported option worth evaluating before committing to surgery. And now you know exactly what to ask for. So here's our question for you. Have you been told that surgery is your next step? Drop it in the comments and tell us what you've been dealing with. We read them, and it helps us decide what to cover next. And if you want to understand what's actually generating your back pain before you make any decision, whether it's the disc, the facet joints, or the SI joint, we did a dedicated video walking through all three. We'll link it right here. And if you want to compare stem cells and exosomes before your consultation, that breakdown is linked too. Subscribe for clinical specificity, not generic advice. We'll see you in the next one.